As Danielle mentioned, the topic can bring about intense feelings and memories. Please pay attention to what's going on with yourself, how you're feeling. If you need to talk with somebody, please reach out. And here are some also, resources, also phone numbers and text options, the National Suicide Prevention Lifeline, and our local resources for the CARES hotline. Oops. Okay, so today we're going to work on learning how to collaboratively develop a safety plan with an individual who's at risk for suicide. We're going to discuss strategies to increase the likelihood that the patient will use the safety plan when they're in crisis. And we're just, by doing that, going to become more familiar with the different areas of the safety plan. We have a mixed audience today. Some mental health providers, community members, maybe some people who aren't specifically trained in mental health. I just want to acknowledge the differences among the audience and encourage questions. The presentation focuses on the different parts of the safety plan, but also strategies for clinicians who are working with individuals in developing the plan. So please feel free to ask questions, raise your hand, write a question in the chat, or unmute yourself, whatever works best. So a safety plan is a powerful tool that helps someone safely de-escalate a current or a future crisis. It's a prioritized written list of concrete coping strategies and resources that the individual has created for themselves with collaboration from their therapist to use when they're distressed, feeling suicidal, with the goal of maintaining safety and regaining equilibrium. It's a personally meaningful, self-directed plan. It's not a no suicide contract. No suicide contracts have no clinical effectiveness and are not patient-centered. They often give a false sense of assurance to the clinician, and more importantly, individuals promise to stay alive without knowing how to do so. Why is safety planning useful? So suicide risk fluctuates over time, and we know that increasing time and space between individuals facing a suicidal crisis and the means to act prevents suicide. We also know that people who've struggled with a suicidal crisis are very likely to experience another one. A known prior suicide attempt is the most robust predictor of eventual suicide that we know of. And when we think of patterns of behavior, like that really makes sense. Unless we make a conscious decision to do something differently, we often very frequently continue patterns of behavior. This follows that same idea. So the safety plan is designed to break the cycle that leads to suicidal behaviors by providing the tool to help people from entering into the suicidal state. And I like to think of this in terms of like having emergency plans. Like every place that we've worked, government agencies, schools, everybody has a plan for what to do when they're in crisis. And this is essentially the same thing, with the goals, again, of maintaining safety, reducing distress, and speeding recovery. So safety plans should be completed with individuals who have made a recent suicide attempt, those who have engaged in preparatory suicidal behavior, who have expressed suicidal ideation, and or have been diagnosed with a psychiatric disorder that increases suicide risk, or if the individual has otherwise been determined to be at a high or intermediate, acute, or chronic risk for suicide based on a comprehensive suicide risk assessment. I could do a whole training on the VA's suicide risk assessment, the way that we assess for risk and determine whether a safety plan should be completed. So if anybody is interested in that information, please feel free to contact me. I'd be more than happy to talk about the tools that we use and how we make the decision whether a safety plan would be indicated or not. A safety plan should take about 20 to 30 minutes to complete and should be completed collaboratively with the individual and the mental health provider. So again, safety planning is part of a comprehensive suicide risk assessment. These are the tasks that the safety plan involves. So you're going to want to identify and assess for suicide risk. You're going to want to obtain the crisis narrative, which means you're going to want to have a conversation about the last time that the person was in crisis and what happened, and really try to get them to break down the situation from the beginning to the end. You're going to want to provide psychoeducation about safety planning, about why it can be helpful, and introduce it. You're going to want to identify warning signs, explain how to follow the steps in the safety plan, complete the safety plan, implement the safety plan. So you talk with the individual about how they're going to use the plan, and then follow up with them at a later date about how well the plan is working. Some tips in completion of the plan. It is really a collaboration. So we can't ever diminish the importance of the relationship that we have with our clients. The therapeutic, empathetic, safe, collaborative, supportive environment that we help cultivate is crucial. Whether we work with this person on a long-term basis, or this is the first and only time that we'll meet with them, the way that we communicate our care and our empathy matters. Our patients are trusting us with very intimate details, life or death situations. Consider what it would take for you to talk about the worst day of your life to someone you hardly know. So think about being a good listener, ways to engage somebody in completing the form and completing it and making it feel like it's a useful tool for them. So for some people, that might be that they write, their handwriting is on the form, that the information is written in language that is familiar to them, that is the way that they would talk. For some people, they don't even like to use the safety plan form, which is fine. They don't like the title safety plan. So it can really be developed to work for the individual that you're working with. And that's really the goal, that it's going to be a tool that is going to be useful to them. And another thing that you're going to want to do in each step of the safety plan is address barriers and use problem-solving strategies to try to help the individual figure out, is this something that I'm going to do? And if it's not, why not? And then help them identify things that would be helpful. Some additional tips. Understand the motivators for suicide from the patient's perspective. Assume that the individual is the expert and that suicidal thinking and behavior makes sense in the context of their history, vulnerabilities, and circumstances. Empathize, validate the patient's feelings and desire to reduce emotional pain, and maintain that suicide is not a good option. In turn, you want to validate the good option. Safety plan is one of the good options. The things that we're identifying on the safety plan are good options, and we want to continue to validate those. Again, just be familiar with the steps, have it try to be more of a conversation with the individual instead of just like marking off the boxes, right? That decreases collaboration and makes it feel less personal. So really the importance of the relationship and the is going to be really crucial to the development of a plan that's going to be useful. You're going to want to help the patient recognize their strengths and their skills. You're going to want to draw on their history to support the positive side of the ambivalence, especially for people who experience chronic suicidal ideation. And then you're going to want to bridge this intervention to therapy goals. So if this is somebody that you're working with long-term, you're going to want to talk about the safety plan in terms of the long-term goals that they have identified that they're wanting to work on in therapy. So as a short introduction, you're going to want to talk with them about the last time that they were in crisis or feeling suicidal. You're really going to want to get down to some very detailed information. Some people will say things like, oh, I don't know, I just go from 0 to 10. And you're going to really want to pin down much more information than that. So you're going to want to talk about what happened earlier in the day, what happened, potentially the day before. Did you sleep well? Were you experiencing chronic pain? You're really going to want to ask some pointed questions to try to identify warning signs and triggers. Discuss that suicidal feelings will pass, but that they can often come back, and that having a plan for how to cope can help them pass more quickly and successfully. The safety plan can help the patient not act on feelings, giving suicidal thoughts time to diminish and become more manageable. Being able to use the strategies within the safety plan can also enhance self-efficacy and a sense of control. In the VA, we often use like a standard operating procedure analogy, because that's a very common thing in the military. So a lot of veterans are very familiar with SOPs. And the safety plan is essentially the same thing, right? The most important thing to discuss is that when we're in crisis, we're not thinking clearly. Problem solving or coping skills diminish during any crisis, especially when we're in a suicidal crisis. The 6 steps to the safety plan. Step 1, triggers, risk factors, and warning signs. So these are signs that I'm in crisis and that my safety plan should be used. Step 2, internal coping strategies. We're going to help our patient identify things that they can do on their own without contacting another person to distract themselves and keep themselves safe. Step 3, social contacts who may distract from the crisis. People I can contact to take my mind off my problems or help me feel better. Public places, groups, or social events that distract me or help me feel better. So in this step, you're not necessarily going to share with the person that you're feeling suicidal, but just being with that person helps you feel better. Step 4, family members or friends who may offer help. So in this step, you would share with a family member or friend that you're feeling suicidal, and have a discussion with them about what's going on, knowing that there's somebody that can help you. And sometimes there's overlap between step 3 and step 4 in the people, but step 3 doesn't involve you telling the people necessarily that you're in crisis, whereas step 4 does. Step 5, professionals and agencies to contact for help. Mental health professionals, services, and crisis lines I can contact for help. And then number 6 is making my environment safe. This is the lethal means safety piece. Ways that I can make my environment safer and protect myself from lethal means. Here's an example of a blank safety plan. And like I said before, you can tweak this form. Besides needing to fulfill all of the categories, you can make the form look like however you want it to look like. So it can be on a computer, it can be, the VA offers a safety planning app, and that's something you can develop the plan within the app. So that works for some people. That's also a way that people have it readily accessible. So you're going to just want to talk with the individual that you're working with about what would work best for them. Step 1. The purpose of step 1 is to help the individual identify and pay attention to his or her warning signs. This requires self-examination, self-awareness, self-reflection. Knowing oneself and the warning signs of distress in the past help us prepare for the future and notice the present. Being in the here and now can be painful, and it is the only time and place where we can respond to our environment, where we can choose to respond intentionally to our environment. In this step, you're going to want to, again, provide some more psychoeducation, talk about mindfulness and how we practice non-judgment of our feelings. We are a place where experiences occur, including emotions. We are not the emotions themselves. This is an area that you're going to probably spend the majority of the time working on because of the fact that it requires a lot of looking within. And that's something that some people haven't really done a lot of before. So this part of the safety plan often takes up a lot of time. They're most effective. The things that you identify are the triggers, risk factors, and warning signs. You're going to want to be as specific as possible, as opposed to vague. So because that's what's really going to help somebody hone in on what their warning signs are. right? So if somebody says something like, when I have a bad day at work, I'm going to want to try to ask about, what does a bad day look like? What does that mean? Is it something specifically about, that bad day? And if that person can identify, yes, when I feel disrespected at work by my boss, okay, that's pretty pointed. That's pretty, we know that if that happens, that's a trigger for this person. Some other thoughts, emotions, behaviors that people can identify and put on their safety plan. I'm worthless, I'm a burden, it's hopeless, I can't stop using drugs or alcohol, I'm a loser, my family would be better off without me, everyone hates me. And then behaviors too, that we're helping individuals pay attention to their behaviors as an indication that things are not going well. Change in sleeping patterns, risky behaviors, loss of appetite, increase in substance use, isolating, and then emotions that are associated with these thoughts and these behaviors: depression, anxiety, agitation, anger, shame, feeling overwhelmed. So some more sample responses: when I feel unappreciated by my family, when I feel overwhelmed, especially by finances, that one's pretty pointed. Financial stress can be really, really hard to manage. And then in reviewing this stuff, you're going to want to remind the individual that when they start to recognize warning signs, they should pull out their safety plan. The plan is a hierarchical plan. So they're going to start step 1, move to step 2. If step 2 doesn't work, move on to step 3. So you're going to want to also explain that the plan should be used in stepwise fashion unless they need emergency rescue. Step 2, internal coping strategies. The purpose of step 2 is to distract the individual from their suicidal thoughts, which can help lower risk. So you're going to help them try to identify specific activities that can serve as strong distractors to suicidal thinking. These should be activities that they can engage in on their own without contacting another person. And they need to be activities that can be done kind of spur of the moment, not things that require planning. Engaging in problem solving or responding to specific thoughts is often challenging to do during a crisis. So, and that speaks to every area, that it's helpful to have these things identified already. The best strategies here are simple, easy to use, and absorbing. Again, you're going to want to be more specific, help the individual identify more specific things as opposed to more vague things. So if somebody says watching television, okay, that can be a good distractor, but it sometimes maybe can contribute to our thoughts that maybe are making us feel unsafe. So we want to try to help them identify things that are going to distract them from those feelings. Watching stand-up comedy on Netflix, that's pretty pointed. Vague, playing with apps on my phone. Specific, using my virtual Hope Box app. That's one of the apps that the VA offers that has lots of different things within it. Please check it out if you have time. Also, going on a hike versus having a list of several hikes that I enjoy, or hikes that would be safe for me to do during this time. Exercising, vague. Specific, going to the gym and weight training. Vague, practicing mindfulness. Specific, some specific guided meditations that I enjoy, that I have identified or maybe saved on my phone. Baking versus baking my mom's favorite chocolate cake. In reviewing this step, you're going to want to ask them questions like, how likely do you think you'll be able to do this during times of crisis? What might stand in the way? And again, provide some additional psychoeducation about the fact that coping memory is like muscle memory, and that we have to practice these skills. We have to practice noticing warning signs, triggers, and even using these internal coping strategies, and that as we use them more often, practice them more often, they're going to start to feel more automatic and more helpful. Again, you're going to want to try to problem solve with the patient to see if they're saying like, oh, this looks good on paper, but I don't really think I'm going to use any of these things. So you're going to want to talk with them about why and help them identify things that they would use. Oops, sorry. Some other tips, if they're really struggling with things, are to list activities that they feel that they're good at, things that make them curious, topics they know a lot about, or anything that they can make with their hands. Step 3, social contacts who may distract from the crisis. People in social settings can be good distractors. Clinicians and formal health or mental health providers should not be included in this step. So the individual is going to identify a person that they would not necessarily inform that they were in crisis, but with whom they feel better or with whom they can focus less on painful feelings. Remind them that if step 3 doesn't work, remind them to use step 3 if step 2 does not resolve the crisis or lower the risk. It's useful to have the phone numbers listed on the safety plan or saved in their cell phone. Specific, again, we want to be specific. Specific places should be identified rather than vague places. Be sure that the identified person or places do not increase the suicide risk. For example, going to the bar, going to the shooting range. And you're going to want to identify places that are readily accessible and frequently available. Social activities that require advanced planning are typically not helpful here. So questions you can ask: who can you contact that helps take your mind off problems or helps you feel better? What places, public places, groups, or social events help you take your mind off your problems? Social contact. So here's some sample responses. People I can contact, have names listed with the phone numbers, places that you can go. Addresses are necessary, you can write those down as well. In reviewing this step, you're going to want to, again, assess the likelihood that the individual will contact others or visit the places listed during the crisis. They shouldn't just be people or places that sound good to the clinician. Instead, they should be people or places that the individual is likely to engage with as distractions when they're in crisis. Shouldn't list places that the individual has never visited or has no intention on visiting. Step 4, family members or friends who may offer help. Sometimes distraction is not enough and the patient needs to disclose crisis to someone who can help. So in this step, they're going to tell a family member or friend that they're in crisis and that they need support. There might be some overlap between the people in step 3 and step 4. Remind the patient to use step 4 if step 3 does not resolve the crisis or lower the risk. Again, you're going to want to try to include phone numbers on the safety plan and that they're in the individual cell phone. Talk about that this is an opportunity for the individual to share the plan with trusted friends and family. And sometimes friends and family can help the individual use the plan when they're in crisis, or they can remind the individual, where's your safety plan? If the individual discloses having no friends or family support, can consider interventions to address social isolation or social skills. In reviewing this step, again, identify potential obstacles and problem solve. Might be helpful to role play with the veteran or with the individual that you're working with. Some sample questions: who are friends or family members who should be included on your plan? Who would you feel comfortable reaching out to for support and help when you're in crisis? Step 5, professionals and agencies to contact for help. Sometimes the individual may need support from a mental health professional or an agency to help resolve their crisis. In this step, the individual reaches out to a mental health professional, a crisis line, or an emergency service for help. Remind them to use step 5 if step 4 does not resolve the crisis or lower the risk. This is an important step. It shouldn't be left blank. If the individual does not name any other professional providers, you can list yourself as a provider to contact if it's appropriate to your role. List the names of the people in the order that the individual would contact them. Include phone numbers on the safety plan and encourage the individual to program the numbers in their phone. Might be helpful to list the days or the hours that the clinician or the agency is available, and remind them to call 911 in the emergency. Some sample questions: who are the mental health professionals or agencies that should be included on your plan? If you need to go to an emergency room or an urgent care center, where would you go? At the VA, we often, and in community care as well, we want to know if they're seeing somebody else besides us. Are you seeing another therapist that we could list on here? Are there other, maybe peer support program? Some more sample questions about and information about the Veterans Crisis Line. You can ask questions about calling crisis lines. Have you ever called a crisis line before? What was that like for you? Would you call again if you were in crisis? What concerns do you have about calling a crisis line? And some sample responses. So this person identified their social worker, the psychiatrist, the Veterans Crisis Line, the text option, the online chat option, Hilo Urgent Care, the emergency room at Hilo Medical Center. And then again, you're going to want to try to identify potential obstacles and problem solve. And as with all of the steps, role play may be helpful. Step 6, making the environment safe. Easy access to lethal means significantly increases the risk for suicide and subsequent death. Doesn't allow the patient enough time to use the steps in the safety plan. And what the data shows us is that reducing or slowing access to means is a highly effective strategy to prevent suicide. A study of survivors of a near fatal suicide attempt indicated that 71% of those surveyed made the suicide attempt within an hour of deciding to take their lives. And nearly 70% of veteran suicides are related to firearms, and approximately 1/3 of veterans store their firearms loaded and unlocked. Increasing time and space between individuals facing a suicidal crisis and a firearm prevents suicide. I have this short video to show real quick, hopefully it pulls up.
Hi, Wendy. We're still seeing your slides, but we can hear the audio.
Can you hear? Can you see now?
We cannot. Maybe stop screen share, then reshare the video.
Okay, yes, good idea. Sorry, thank you. Okay, let's see. New share. There we go. Thank you. Can you see now?
It is still showing your original slides.
Okay.
Oh, there it is. Perfect.
We serve you.
Is there a way to increase the volume?
How have you been feeling?
Perfect. Thank you.
We talked about anger, sadness, not being able to get out of bed.
And about times you feel so hopeless, you just don't want to live.
We talked about times you need to keep yourself safe.
He has a gun, like lots of veterans.
But through rough times,
You shouldn't be around your gun.
How it could help to lock it up with a gun lock or in the safe. And I would hold the key until things got better.
We decided to get it out of the house and store it somewhere else for a while.
I was there to support him.
I wanted her to know that I cared and that she wasn't alone.
Never really talked much about feelings with anyone. I thought it would be hard to talk about suicide, but we took an oath, always have each other's back.
I started this conversation because, well, I had to.
I had this conversation and I'm glad.
I had this conversation and it saved my life. Sometimes you give help, sometimes you get help.
Can you get back to the slides here? Okay, can you see the slides again?
I can. Perfect.
Okay, great, thank you. I really like that video because it isn't necessarily a clinician talking with a patient or an individual about lethal means. That video really speaks to me about family and friends and how we can help support each other in terms of being in crisis. So when we're working on this step as a clinician, working on this step with an individual, we're gonna want to assess whether they have a specific method or a plan for suicide. This is part of the full suicide risk assessment. So sometimes people will identify a specific method, something that they've been thinking about. Sometimes people don't have a specific method in mind. But if somebody identifies, yes, I have a firearm, that's going to be something that you really want to talk about with them, that you're going to want to gather as much information about as you can. And you're going to want to ask about access to any lethal means. So sometimes people will identify, yes, I own 6 hunting rifles that are all locked up in a safe. But then they also may identify, and I own a handgun that I keep unlocked and loaded underneath my mattress. So that's the weapon that you're going to want to really explore with them. The hunting rifles appear to be secured appropriately. It's the handgun that you're going to want to have extensive discussions about. And again, this is a collaboration with the individual to find acceptable voluntary options that eliminate, reduce, or slow access to these means. And I just want to go back to the first part where we talked about the relationship. This is a really hard conversation to have with people. I can just say that. Oftentimes people don't want to talk about this, or they feel like you're having this conversation with them because you want to try to take their guns. And that is the opposite of the conversation, the purpose of the conversation. The purpose is really to help keep them safe. And the way that we can kind of convey that is through the relationship that we have with the individual that we're working with. You don't want to limit the discussion of lethal means to the one the individual identifies as most likely. So I gave that example of owning several firearms. You could talk with somebody about, and they identify, yes, I'm most likely to, or I've been thinking about overdosing with my medication. So that they've identified that that's the most likely option. You're still going to want to ask specifically about other access to lethal means, including firearms. You're going to want to explore with the individual who can help them limit access to lethal means. Sometimes adding items, pictures, quotes, etc., to an individual's environment can remind them for reasons of living. Specifically related to firearms, there's a program where you can get, it's like a picture, essentially, any kind of picture of your family, a dog, a pet, and it goes on top of your firearm, so that can be a way to remind people of reasons for living. You're going to want to ask questions like, what can we do to make the environment safer? What items in your environment might you use to hurt yourself? Always ask about access to firearms. If someone reports that they do own a gun, you're going to want to ask about how they're storing the gun. Are they storing the gun unlocked and loaded underneath their mattress? Are they storing the gun unloaded and locked? Are they storing the ammunition separately from the gun? At the VA, we have access to gun locks. Please, if anybody in our audience works with veterans or is interested in getting some gun locks from the VA, please feel free to contact me. I can definitely send you some. That's always a great thing to be able to offer people and talk about how to effectively use gun locks. Discuss options for safe storage. So sometimes locking the gun and giving the key to a friend or a relative, removing the firing pin and giving to a friend or a neighbor. My coworker, Travis, he always gives the option of putting the key in the bottom of a cup and filling it with water and putting it in the freezer. So some sample questions. I know that guns are important to you. Let's work on a plan that will keep you safe and work well for you. Another lethal means area that you want to for sure identify is access to opioids. So veterans who are prescribed opioid medication, either through the VA or one of our community providers, are automatically also given a naloxone rescue kit. So it's important to talk with our patients about ways to limit immediate access to large amounts of medication during times of crisis. At the VA, we have a policy that if somebody is determined to be at high risk for suicide, they only receive 2 weeks of medication refills at a time. So as noted above, you want to try to have discussions about ways to limit access to medication. Another way would be to purchase, small bottles of, say, ibuprofen, 20 tablets instead of like the 500 tablets from Costco. Disposing of old medication that's no longer needed through appropriate and safe means. At the VA, we have medication bags that veterans can mail in old medications, can drop off meds at police stations, police departments. They have drop boxes for medications. A lot of areas also have events a couple times a year where people can bring in old medication. Want to make sure that we're disposing of the medication safely. For someone who is not a veteran, here's a resource for a naloxone kit from the Hawaii Health and Harm Reduction Center. So you can request a free mail order naloxone kit through this agency. So some sample responses. I'll get rid of my old medications by sending them in through the medication return bags the VA provides. I'll consider getting a lockbox for my meds. Another option for medication is to have them blister packed. So, possibly just the effort of having to take out, open all of the blister packs is going to create some time. And then again, identify people who can help protect them from having access to dangerous items and that person's phone number. You're going to want to set a follow-up date to talk about how things are going with the implementation of the plan. Set a date to review with the individual whether they have been able to implement the steps in the plan. Did you talk to your neighbor, Denise? Has she agreed to help you? Did you give her the key? Did you lock your firearm and give her the key? We don't want to explore ambivalence. Explore ambivalence or doubt about reducing access to lethal means. Like we talked about before, sometimes often, almost all the time, this is a very hard conversation. And sometimes people keep access to lethal means as a way to manage their suicidal feelings. For some people, it feels like, well, I still have this as an option. But to have an open discussion with them about how limiting access to that option it makes a significant impact in saving their lives. And then set a date to follow up with them that the agreed upon steps have been implemented. If anybody is interested in additional training on lethal means safety counseling, please feel free to contact me. The VA also has a training program through the Suicide Prevention Resource Center called Counseling on Access to Lethal Means. So when you're wrapping up the safety planning intervention, you can verify the individual's physical address. That's a good thing always to do in the event that you may need to call for a welfare check, and just make sure that if you're concerned for them at some point in time, it's important to make sure that you have their address to do so. The My3 Safety Planning app, that's an app that you can download on Android or Apple, and it walks you through the safety planning intervention. The Virtual Hope Box app, an app that the VA offers that there's lots of different things in, mindfulness, some more physical health care stuff, some distress tolerance skills. There's lots of different apps within that. MakeTheConnection.net is, there's over 800 stories of hope and healing related to veterans, and they're You can search by era, by gender, whether you were in combat or not. There's some amazing stories on that page. And then vetsprevail.org is a peer support organization that's specifically for veterans, available 24 hours a day. So before you end the session, you're going to want to review the entire safety plan with the individual, assess the likelihood that the safety plan will be used, and problem solve around barriers to using the plan. Ensure that the individual receives a copy of the safety plan. Discuss where they're going to keep the safety plan. So if people are going to have a paper copy of the plan, talk about having a couple different copies to leave in different areas, one in the car, one at home, one at work, or whatever is going to work for that person so that they always have access to the plan. The other option, of course, is entering it on their smartphone. Most people always have their phones, so that's usually a good option. If possible, it's good to try to obtain a safety contact. So a person, a family member, a friend, or another trusted person that you could contact if you were concerned about the individual's safety and you were unable to reach them. Ideally, they would complete a release of information for the safety contact. If the individual declines to provide a safety contact, that's fine. Can just discuss why it can be helpful. The safety plan is not a static one-time intervention. That's something that's important for us to remember. It's something that we're going to want to continue to check in with the individual that we're working with on how is it working? Have you had an opportunity to use any of the strategies? Have identifying the warning signs, the triggers, has that been helpful? And if they say, no, I haven't even looked at it. Okay, so that's a good place to start. You know, you can talk about, well, why haven't you looked at it? Are there things that are stopping you from using the plan? And really try to hash that out with the person. And like we talked about before, it could just be that it says safety plan, or that it's, you know, not written in a way that's useful for them. So it's something that it's useful to revisit on a very frequent basis. Talk with the individual about their plan. Do you remember it? Have you used it? Was it helpful? If it wasn't helpful, why? What can we do to make it helpful? The VA offers a suicide risk management consultation program for providers who serve veterans. So for any of our providers, please feel free to reach out to the VA to initiate a consult. We know that we cannot prevent suicide alone at the VA, and your voice and local expertise in reaching our veterans, their families, their caregivers in our communities is invaluable. So that's all I have for today. If anybody has any questions.
Thank you so much, Wendy, for all of that fantastic information. It's just such vital information to be sharing. I know there were a couple of questions people had about whether or not they'd be able to get a PDF of the slides today.
Yes, definitely. What would be the best way for me to get those to people?
If you will email the PDF of the slides to Danielle, I have a list of everyone who attended within this room, and I'll be able to redirect them to the attendees.
Okay, that sounds good. Yeah. Any other questions?
I see a lot of thank you and positive affirmations for all that fantastic information that you're sharing, and for helping veterans. Some really beautiful comments in the chat.
Yes, thank you so much. I am very happy to be here today and so blessed to be able to do this work. So Thank you all for your time. Yes. And my contact information will be in the slides too. So please, anybody feel free to reach out to me if I can help in any way.
I did have a comment that I see. I don't want to lose it. I have a friend who, or do you see the?
Yes. Oh, I'm sorry, I'm just going to go back. I have a friend who does not want to reach out because they don't want it on their record. What can I say to still encourage them? So one thing that I would offer is that the vet center is a good option for people who are continuing to actively serve our military. The vet center is a separate part of the Veterans Health Administration, doesn't share information with DoD. That's one important piece. The other thing that I would just encourage that person to reach out. I've done some work with active duty, and although I do know that that is a concern for a lot of people, the military is really set up to help support people. They really have a lot of things in place for suicide prevention. And if he or she doesn't want to reach out through the military, please feel free to pass on the Veterans Crisis Line information to them, can help link them to either somebody at the VA or another resource provider that can help them. Thank you. Somebody said, what is the best way to process the loss of someone when you have already made progress on a safety plan and the person did not show outward signs of their suicidal feelings? That's really challenging. I'm assuming that what you're saying is that that person then went on and died by suicide. And anytime that we lose somebody it's very challenging and hard for us as providers and just as individuals, right? So that feels like you saying the person didn't share with me what was going on with them. And it's incredibly hard to help people if we don't know what's going on with them. And I would go back to, just the formation of the relationship. And there are times that it's going to take people a long time to feel comfortable talking with you. And that is just the nature of working with some people. That doesn't necessarily speak to your clinical abilities. It just is, that can be a challenge in working with some people who are more introverted and have a hard time sharing things. And again, we're talking with people about one of the hardest things that we can have a conversation about. So you can remind yourself to show yourself some grace too, because it feels like you're kind of looking back and saying, feels like there's more I could have done. It's very hard to know how we can help people if they're not sharing with us what's going on. Is this safety planning most useful for veterans, or can it be used with other populations as well? I really like safety planning because I feel like it helps us identify skills related to distress tolerance and being able to recognize things within ourselves that start us down the path of decreasing our ability to keep ourselves safe. So I feel like safety plan is useful for everybody, just to even start exploring those warning signs, those triggers. We all have those, even if they don't lead to suicidal ideation. We all have things that set us off. So to be able to start talking with individuals about recognizing those things and not passing judgment necessarily on them, but just on being able to recognize them within ourselves and deciding if that works for us, or is that something that we would like to try to make a change. Yes, any thoughts about how this might be used with youth? Yeah, I think that this could be really useful in work with youth for those same reasons, like building distress tolerance. I don't think that's something that we talk enough about with youth, about how to manage feelings of distress, and what we would associate more with like negative emotions, even though emotions are not negative or positive, they just are. Like, they're just things that they are. We are the place where emotions happen, but we are not the emotion. That to me is one of the most important things to remember. So Travis said, I like the safety plan because it's an action plan versus the old way of saying, sign this contract that you'll not do suicide. Yes, I agree. And it provides some specific things to do, right? It's specific, like you said, Travis, an action plan. And to be able to identify these things when we're not in crisis really help us identify things that are going to be useful when we are in crisis, as opposed to, say, working on this plan when we're in crisis. Thank you, everybody, for all your positive feedback. I appreciate it.
Yeah, I don't see any other questions. Thank you so much for joining us and sharing your wisdom with us today, Wendy. It was just such pivotal and vital information for us all to get. So again, a warm mahalo. For those of you who are joining us in room 2 for the second breakout, this is will be occurring. So feel free to keep it running or to jump off and jump back in. And then to follow your PDF of the additional links to get to where you'll be going if you're not joining us here today in the second breakout. Enjoy your break, and I'll see everyone at some point.
Thank you all.